Well, what I want to do with this now, I want to make a transition to our myth versus fact section, something that I do all the time on the show. And really to set this record straight at the beginning of the show, I was talking about the reason why I wanted to create 2 Year Off with Dr. G is to help not only eliminate some barriers, but also to dispel some myths. And we're again talking about building trust and delivering truth. So I'm going to ask this question, myth versus facts, how it works, super simple, kind of more like rapid fire. I'm going to say a statement, and then my panelist is going to maybe give a statement or 2 back on what they think it is. You know, maybe myth, maybe fact, but we're really, or maybe both. I've had some cases here, some statements that I've done on this show, and it's been both. But I want to just try to set the record straight to give people information out there so they can talk to their doctors and find ways forward in their healthcare. So the first statement goes to Dr. Oware. Here we go. Myth versus fact. Here we go. Here's a statement. If there is a dosage miscalculation, anesthesia can wear off before surgery is over.
That is a fact. If you don't give enough anesthesia, then absolutely it can wear off, and then you know, depending on the drug, then you have to give more. As mentioned before, we give our drugs, it's weight-based. So if for some reason you don't have the correct weight, or if you didn't give enough, it can wear off before. A lot of our drugs are meant to wear off with time, and then a lot of our drugs can be reversed. So that's obviously the plan for anesthesia, to wear off eventually or to be reversed. But if you don't give enough anesthesia, then it can wear off earlier than you want it to, and then you'll have to give more.
This is why you guys are so skilled at what you guys do to make sure that we have the positive outcomes that we want our patients. Here's the next statement. This is for Dr. O'Rourke. Here we go. Myth versus fact, the anesthesia version. Here we go. Anesthesiologists leave the operating room after the surgery begins.
That's generally a myth. There's actually a couple different ways the anesthesiologists practice. One that I'll be doing tomorrow is I am the one person in charge of the anesthesia for the patient. So I greet the patient, I take the patient to the operating room, I'm with them for the entire surgery, and then I accompany them to the recovery room, and then I sign off to a nurse who will take care of them there. So that's a very common practice. I practice at an academic center with residents and also with certified registered nurse anesthetists. That's called a care team model, which is another common practice in the United States. In that scenario, I work with a resident or a CRNA. And in that scenario, the 2 of us are typically in the room putting the patient to sleep. And then at some point after the patient has been anesthetized, typically after the surgery has started, I may in fact leave the room, but I'm leaving the room not with no one taking care of the patient. I'm leaving it with another competent anesthesia provider with the patient taking care of the patient. And in that scenario, typically, I take care of more than one patient at the same time. I'm in the operating room for all critical periods of the surgery, but I'm not there necessarily the entire time. But the only time you would leave the room is if someone else is there taking care of the patient.
Thank you for the clarification. Here we go, Dr. Hong, myth versus facts. Here we go. Here's a statement. Patient comorbidity is an important factor in determining the outcome of surgery.
I would say that's true.
Right.
You know, patients come to you with all different types of risk factors and illnesses, and surgery can be emergent, it can be elective. Surgery itself is a stress upon the body, and so depending on how you're going into the surgery weighs into the risk overall and how you're going to fare during the surgery and afterwards.
All right, thank you. Here we go, Dr. Oware, myth versus facts. Here we go. Here's a statement. Anesthesia can block your memory.
Well, that is a fact, because there are certain types of drugs that we use that can block the memory. Obviously, we don't want the patient to be awake, so if you're doing a general anesthetic, they're not going to remember the surgery. But certain drugs that we use, certain anti-anxiety drugs, Versed being a common one, can cause some amnesia. I've had it myself before a surgery, and I'm like, I know, you know, they gave it to me in pre-op, and I know I was awake until I went into the operating room and they got all the monitors on, but I don't remember any of that. So I did have some amnesia, even though I was awake before they actually put me to sleep in the operating room. So that is a fact.
Oh yeah, I've been in those shoes too, and it's like, oh, all right. Next thing I know, I'm in the recovery room. All right then, there we go. Here we go. Myth versus facts. We'll do a couple more of these. Here we go. Dr. O'Rourke. Here we go. Myth versus fact. People who are smokers may need more anesthesia than do non-smokers.
It depends. I'm going to say that's generally a myth, but it depends on the type of anesthetic we're talking about. But generally, there are risks of anesthetic associated with smokers, but generally especially for IV anesthetics, the dose is typically the same.
And so, it's interesting, I want to piggyback on that, you mentioned earlier that, there's so many different types of anesthesia when it comes to surgery, and so many things that are just not general anesthesia. I think as my patients that are smokers, I think of suddenly like irritated airways, and if that could be an issue, certainly when you're going to go ahead and certainly obviously intubate the patient if you have to intubate them. But if you're talking about obviously the IV anesthesia or something like that, this might be a moot point.
Yeah, but there's definitely, when you see someone, you can tell how long someone's been smoking when you're taking care of them and when you're bracing and removing a breathing tube. Someone in their 20s who smokes, 30s, 40s, 50s, 60s.
You've seen it.
You should stop smoking. Everyone should stop smoking right now.
And there you go. And I should reference, I did a show on lung cancer, so certainly go back to that on my website, www.drmarcombs.com. We'll do a couple more of these. Here we go, Dr. Hong. Here we go. Here's a statement. Chronic pain is a normal part of aging.
Well, it is true statistically that as you age, things tend to wear out, and as a result, joints can get painful, muscles get painful. But we don't have to go down without a fight. And I treat quite a few aging elderly patients that are otherwise healthy, that want to stay active. And if you are burdened by pain and you get less active, it really has a ripple effect on their whole state of health. So yes, pain does occur generally as you get older, but in 2019 we have tools that can very effectively treat pain so that aging individuals can remain active.
Excellent. I'm going to throw this one to Dr. Oware. Here we go. You'll like me for this one. Anesthesiologists are critical members and key members of the patient's healthcare team.
That is a fact.
I lobbed that one to you.
Like I said, anesthesia is a very complicated field. Obviously, we're part of the care team. We communicate with our surgical colleagues to, formulate a plan for the patient, communicating with the patient, talking about comorbidities and what's the plan. Because, even though most surgeries may require general anesthetic, maybe if they have lung disease or, heart disease, maybe they wouldn't tolerate the general anesthetic. Maybe a spinal might work better for those patients. So again, there's a whole planning that goes into it, and we are partners with you as the patient, partners with the surgeons and the whole surgical team, the nurses in the operating room. It's like a well-oiled machine.
I'm going to give one more. I got a bonus myths versus facts, so I can even it out because everybody's got almost essentially the same amount of questions. So here we go, Dr. O'Rourke. Here we go. Trying to even this out. Here we go. This will be the last myth versus fact. Here we go, Dr. O'Rourke. Statement: spinal anesthesia causes back pain.
It's probably a myth. There's actually a lot of concern about this regards to pregnant women having epidurals, which is similar. It's both a needle in your back. Generally, it's a needle going into your back to do a spinal anesthetic or to do an epidural anesthetic. The big study that I'm aware about this was in pregnant women who received epidurals, and sometimes women have back pain after labor and after carrying a child, which can cause changes in the back. So basically, they took women who had an epidural and women that did not have an epidural, and both had similar rates of back pain afterwards. So generally, it does not. There are other side effects of a spinal anesthetic and an epidural anesthetic, but generally, chronic back pain is not typical.
All right, well, thank you very much. There's myths versus facts, anesthesia, done and done. So we got just about 5 minutes left, guys.